Hi, I'm Joyce Harper, Professor of Reproductive Science at the Institute for Women's Health at University College London. Welcome to Season 3 of my podcast, Why Didn't Anyone Tell Me This? This season, we'll be diving into topics that explore how to achieve good health and happiness. I'll be speaking with leading experts who will provide evidence-based advice and debunk some of the many myths around our health. Additionally, I'll be having conversations with individuals who bring unique perspectives through their lived experiences. In Season 3, we'll cover a diverse range of topics, including reproductive anatomy, inspiring female icons, chronic health conditions, factors that influence our well-being, and global women's health issues. I really hope you enjoy Season 3 of Why Didn't Anyone Tell Me This? Welcome to the mini-series on understanding reproductive anatomy. And today we will be talking to Dr. Pippa Sangster about the penis and testicles. Pippa is a consultant urologist at University College London Hospital and is the lead of the male infertility service. I want to explain what a urologist is. They are a medical doctor who specialises in the urinary tract and reproductive system for men, women and children. Pippa qualified from Guy's and St Thomas's Medical School, London, in 2001. She has further degrees in psychology, a BSc, and was awarded the gold medal in the Urology MSc. She holds an Honorary Associate Professor post within reproductive health. Her main area of expertise is andrology. Now, an andrologist is someone who focuses on male sexual health and the male reproductive system. Pippa particularly works with men suffering from infertility, erectile dysfunction, Peyronie's disease, and associated endocrine-related issues. In addition to medically improving men's sperm counts and health, she performs surgical sperm retrieval and is a world-renowned expert at a procedure called MicroTESE and varicocele repair. Welcome, Pippa.
Hi, Joyce. Lovely to be here. Thank you for inviting me.
I'm very excited today because we've spoken a lot in this mini-series about female reproductive anatomy, but today we're heading to the penis and the testicles. So I wanted to start, Pippa, by asking you why you chose your career and specifically why you wanted to become a doctor specialising in men's reproductive health.
It's a question I'm asked quite often because it's a bit unusual to have a female urologist. So we're officially called andrologists when we look after sexual dysfunction and fertility. I got into medicine. I had a poorly sister when I was little, and so we were in hospital quite a lot with her, and I was always amazed at the doctors and nurses that could make things better. So I thought, well, I definitely wanted to do that. Definitely wanted to help people. And then when I became a doctor, my first job was on a urology firm, and I just realised that, well, two things. One, all the urologists were lovely. So every urologist I ever met was great. And then the second thing is I love the patients. So the patients at that stage were little old men who used to come in their suits and ties and were just so delightful to look after. And I knew I wanted to be a surgeon. I couldn't bear medicine. And got into it that way. And then I think if you were to ask my school friends from like not primary, secondary school, they would say I probably always talked about sex. And so I find it very easy to talk about sex, and it's fascinating and interesting. And I realized that there was a really big gap in the kind of market, first of all, for talking about sexual dysfunction in men, which is a massive problem, but then also male infertility, which I know we're going to get it back to later. But male infertility is just ignored completely. And there's not many people who really understand it. And I'm fascinated by it. I've got lots of babies. So I've got four babies, and husband said I couldn't have more. So I just thought, right, well, I'll help other people have babies then. So I get to have cuddles every now and then instead.
Fantastic. And I was the same. I was that teenager who always talked about sex. And I think I told many people their first lessons about sex education when we were at secondary school. So we are talking about the penis and the testicles. So I know you've got a model, but most people are going to listen online, but we will have a little clip. So those that want to see the model can look at the clip later. But let's start with some basic anatomy. So can you explain the anatomy of the penis and the testicles?
Sure. Fine. So I'm going to. So it seems incredibly basic, particularly when we talk about the penis. But when you think about the penis, you just need to think of it in tubular structures. So there's two big muscle tubes that run down the front of the penis. And then at the back, there's another tube, which is the urethra that we pass urine out of. And so those three tubes are what comprise the body of the penis. And then you have the head or the glans of the penis, which is the top part of the penis. And then you have a foreskin, which you may or may not have. And foreskins are interesting. We could probably spend a whole session talking about foreskins. We won't, don't worry. But men can have been circumcised for religious reasons, for cultural reasons, or they might have had a problem with their foreskin, which means the foreskin had to be removed either in childhood or adulthood. And having a foreskin removed in adulthood is very common. So when you look at penises, they are incredibly different. No two penises are the same in terms of what they look like when they're flaccid or what they look like when they're erection. And so if we think a little bit just about how the penis changes its appearance, it's all to do with erection and blood flow into the penis. So there's two big bars of muscles that run up and down the penis. The arterial blood flow flows into the penis, and then it gets stuck there, and it gets stuck there by the veins being compressed. So erection is an incredibly complicated process, and to understand erection is how we need to understand how it can go wrong. And there are so many different ways erections can go wrong, which causes a lot of distress to men. But that's the kind of basic sort of structure of the penis. You then have the testicles, and the testicles are, or as my sons used to call them, peanuts. Definitely not peanut size, but the testicle sizes range very dramatically in men as well. And what we want men to do is to get used to examining their testicles and feeling what's normal and what's not. And so obviously they have the bulk of the testicle. And then on the back of the testicle, we have the epididymis. And that's the tube that the sperm travels through. And then from the epididymis, it runs into another tube called the vas. And so most people will have heard of a vasectomy. And the vasectomy is just where we cut the tube to help if patients want to become sterilized. And then the bit that I think is really interesting that not enough people know about is from the vas, the sperm travel into this little structure called the seminal vesicles, and that's deep inside the body. And so when men are having sex or masturbating and ejaculating, it's actually those seminal vesicles that have stored the sperm and squeeze and pass down into the penis. And so it's not that the sperm is coming from the testicles, but it's coming from those structures. And then from that point, we go down into the prostate, which wraps around the urethra, the water tube. And if a man were to ejaculate or masturbate or sex, most of the ejaculate that will come out is actually just secretion. So it's food from the prostate to keep the sperm healthy. Only kind of 0.2 of a mil is sperm. So if you were to have a vasectomy, you wouldn't notice the ejaculated volume pretty much looks the same. And then from that, it travels into the urethra and the penis and then up to the tip of the penis. And so that's the kind of very basic anatomy of penis and testicles and what's going on inside their pelvis.
Fantastic. I mean, we're going to delve into a lot of those parts in more detail and what can go wrong, especially. And as you said, men really need to be comfortable with checking themselves. As we do a lot about women checking their breasts. And we heard with Ezio about how women should even be checking their vulva and look for changes in there because there can be vulval cancers and other things that can happen. And I think one really important message from this podcast is men need to feel comfortable and check and know what's normal for them. And if there's any problems, then they should seek help. Any more thoughts about that, Pippa?
Yeah, absolutely. It's just vital, particularly when, we know that testicle cancer, which is, the second most common cancer in men, it has these two blips of age range. And the first age range is around the teenage years where things are changing in the scrotum and boys need to become comfortable examining themselves. I have two boys and they can't bear it when I talk to them about testicles and penises. And that's with a mother who talks constantly about penises and testicles. But it's just explaining to them, they need to know what's normal. And then once you understand what's normal, then you can understand change. And it's the change that's so important. And obviously, puberty for all children going into adolescence is very difficult. It can be quite scary. And what's normal and what's not normal is really difficult, particularly when there's such a massive variety of what a penis and what testicles can look like and feel like. And we have to recognize now that our children have access online to things that we didn't have when we were younger, and that puts them. That you'd hope that made them feel better understanding things, but it doesn't, because what it does is it puts a lot of pressure on them as to what's normal and what's not, because I always say to people, if you're incredibly clever, you're going to go into research and become, some, professor. If you're Usain Bolt, you'll be a really fast Olympic runner. If you have a very big penis, that might give you some professions that you want to show your big penis in. So it's not normal to see some of the things that are out there on the internet. And the same goes for things like pubic hair and what they do with their penis, what they don't. It's really confusing for children. So it's very important we all get very used to talking with our kids to say, look, what you're seeing online is not necessarily what we would classify as normal. Whatever anyone wants to classify it, normal is the sex.
Let's talk about one thing, which is probably the elephant in the room: the size of the penis. Now, as you said, if you've got a big penis, what's a normal size, average? Let's say no, not use the word normal. What's an average size penis? What's a big penis? What's a little penis? How are they supposed to know?
I don't even think that they should go there with the tape measure. I really don't, and I feel really uncomfortable talking about penis size, because I have a lot of men will come and see us about small penises, and what's officially a small penis is sort of two standard deviations, below 7.5 centimeters, whatever. But, I actually think that those numbers are really unhelpful. And there is so much pressure into what is normal, what's big, what's not. And, I was in a really interesting conference last week, which is purely about male sexual function. And it was a lot of talk about, what we can do to help men improve the size of their penis. And I sat there as a woman in the audience thinking, I just wish that we would play down the importance of penile size, because it's just not that important when it comes to sex life. If you're having sex with a woman, and obviously it's different, whoever's having sex with women or men, but if you're having sex with a woman, women don't tend to orgasm from penetration. They orgasm from clitoral stimulation. I always say, actually, flowers, foreplay, being kind to someone, so much more important than the size of your penis. So, honestly, I think we need to move away from penis size and what's normal and what's not. What you're born with is what you've got. We are very bad at making it bigger medically. And in fact, what is open on the black market and down dark streets of injecting things into penises, you'll be amazed what is available in this country and throughout the world. And I can't tell you how much of our time is spent trying to reverse it and trying to take it out, because it does not work. You can't make your penis bigger. So it's about managing expectations. What you have is what you have, and trying to kind of psychologically support men and young boys into that. It's so much more important.
I didn't know there was a black market of things that men were injecting into their penises. Is there?
Absolutely. Yeah, huge, huge. So things like I almost don't want to say it because I don't want you to go looking for it. Just know that it's bad. So, but
Yeah.
injecting silicone and Vaseline and various things like that. I'll say it again. It doesn't work. It's a disaster. It doesn't work. Do not do it. And actually, once it's done and it's stuck in the penis, it's so difficult to get out. And it's just such a disaster when we have to try and take it out. So, I really it's different to breast augmentation, where we have many years of good surgery, good results. We just don't have that with penile augmentation, and so I'm really anti it. So yeah, you're here. I'm not massively keen to talk about penis size, apart from just to say, you're perfect. Just work around whatever you have.
Love your penis for sure. Right. We'll change the subject. So let's talk about hormones. So men probably know, I think all of us probably have heard of testosterone, and we associate that with men. There's lots of discussions now about women and testosterone, especially the menopause. We're not going to go there. So can you tell us a bit more about what testosterone is doing in men?
Sure. So testosterone is incredibly important for men, and it tends to, when you're born as a baby, you'll have a little, like a mini puberty, where they have a tiny little spike of testosterone, and then it goes very quiet until you go into puberty. And then as boys start to go through puberty and the testosterone increases, that's when everything starts happening in regards to puberty, sexual function, and erections. And then through men's lives, the testosterone, can go up and down if they're poorly, if they're unwell, obviously if they've had surgery on their testicles. There are a number of things that can cause the testosterone to vary. And then as you age, the testosterone will obviously go down a little bit as well. And, they talk about a rate of about dropping about 1% per year. But actually, the majority of older men still have a normal range of testosterone. And this is what the problem often be is, well, what's a normal testosterone? The range is massive. So when I look at my blood result, my reference range for a testosterone is anything is normal from 8 to 30. So that's a really big reference range. If you think that we don't often see men with testosterones above 30. So normally you're sort of seeing them in the late teens. If someone has a level of between 8 and 12 and they have symptoms of a low testosterone, so by that I mean potentially poor libido, erectile dysfunction, feeling tired, struggling to put on muscle mass, then we often talk to them about treatment. But the problem with testosterone is it's almost a bit of a dirty word, in that people have been, a black market testosterone, and getting their T-shot, from the gym and exercising and doing it in quite a quiet, secretive way, that it actually becomes a bit of a difficult topic. So men can have experience all those symptoms and not be sure about what to do, and embarrassed about potentially coming to a doctor. The most important thing to remember is if you're having those symptoms, get checked, because there are men who have very significantly low testosterone and they feel dreadful, and we can improve it. We need to do blood tests, but that blood test has to be first thing in the morning. So a man's testosterone is always highest in the morning, and then it starts dropping down. So as a rule, we always say, look, you must do your testosterone blood test first thing in the morning. And if it's low, we'll repeat it just to make sure that there was nothing that was causing a dip. But one of the biggest issues men have as they age is most of testosterone in their bloodstream is not free. So it's bound to a protein. And actually, they only feel the good stuff, the free testosterone. And as they get older, the amount of protein increases. So the amount of free testosterone drops down. So actually, we need to do a whole array of different testosterone tests and blood tests to see, actually, is the problem here that your free testosterone is not great? And do we then need to think about giving you supplementing testosterone? But one of the important things to say about supplementing testosterone, particularly if you haven't done it via a doctor, if you've done it via maybe somewhere that you shouldn't have, or someone who's not keeping a close eye on you, is if I were to give a man exogenous testosterone, that has a really negative effect on their fertility, and that their sperm count will drop very dramatically. So again, I struggle sometimes. People will come in from their trainer, their gym trainer, who will say, "Well, look, we'll give you exogenous testosterone. Don't worry about the fertility, because we'll give you other medicine to try and keep on stimulating your testicles." And it often doesn't work. And so they come in and they feel a little bit anxious about telling me what they've done or what they're taking, and trying to unpick what medicines they've been having to try and sort out their hormones is a difficulty. But, I think GPs and primary care and urologists are really used to dealing with these problems now. So that, go and speak to your GP about it. If you're having those symptoms, if you're worried that your testosterone is low, don't just start taking testosterone without, taking all the blood tests and trying to work out what's going on.
Wow. So it is really complicated. And is there the case for men as there is for women? Because in women's health, we've got a lot of tech coming out now that's telling women that by measuring their various sex hormones, they can empower themselves and learn all about their body. But what we're seeing is people with totally normal hormone levels getting tested, then getting anxious, and then some of them getting treatments that they don't need. Does this happen in men? Are men getting tests for testosterone and then thinking they need more testosterone rather than having any they haven't got any symptoms, they're just normal? But is there a sort of
No,
men's
I
tech?
think it's
No.
the reverse. No, that they feel they have those symptoms, and then the worry is they start taking testosterone without doing the test, because I think it's different for men and women in that regard, that the female hormone maybe not so useful to test as you're going through menopause, and you're the expert on that, not me. But for men, it really can give us a good idea what's going on. We've got this whole pituitary axis that we need to look at. Is their pituitary working? Are we producing the right hormones to stimulate the testicles? It's very complicated. I've spent years learning it, and I'm fascinated by hormones, but I see people fiddling around and messing with hormones who, A, don't really understand it, and B, they then don't watch the patient. So, you have to have blood tests. You need to be monitored. We need to make sure you're responding in the right way, not too high, not producing too much estrogen as a kickoff, all of these really complicated things. So you really need to find someone who knows what they're doing, be it an endocrinologist, be it a urologist, someone who's got experience. Just, don't start injecting yourself with testosterone until you know what's going on. But again, it's this taboo of can I speak to someone, and is there a problem? Can you help me with this?
My biggest message on everything I always say is, if you're in doubt, please go and see your doctor. Don't start doing anything. There is definitely a
Yeah.
market, especially in women's health, of people self-diagnosing and then self-treating, and it's a bit of a disaster. Now, you did talk about
Yeah.
testosterone dipping as men get older. So this is a million
Mhm.
dollar question. Is there an andropause, so equivalent to the menopause?
Well, I think, as we age, our hormones disappear. We know that, our hormones go down, but it's different for men because that's not a given. It's not definitely going to happen. And I see a lot of men in their 50s, 60s, 70s with testosterone's higher than the younger man that I've seen. The problem with that age, that testosterone range I told you that we have, we use it for the same for a 18-year-old as we do for an 80-year-old, and we need to be using more of a sort of specific age range. But no, I don't feel that men have the same issue as women have with the menopause, but that doesn't mean to say that there aren't a significant number of men there who are finding their testosterone is dipping down and it makes them feel dreadful.
If it is, go and see your doctor for sure. Right, let's get back to
Yeah.
some basics. So, again, I think people know this, but it's good to hear it from you. The function of the penis and the function of the testicles.
So your penis is there so you can pass urine and so you can have sex. And those are the two most important things that you need to do with your penis, for pleasure. It's really important. But obviously, emptying your bladder is vital. And if there are problems with the urethra, the tube running down the penis to empty out the bladder, then men are in a lot of trouble with that. So, really important that, if there are problems with men passing urine, bladder health and kidney health is vital. So, that's the main function for the penis. And then for testicles, our two jobs are making sperm and making testosterone. And so those are the two functionalities of the testicles that are so important. So if someone loses their testicles, those are the two things that we worry about.
And you mentioned about men checking their testicles. Is there anything else they should do to look after their penis and their testicles?
So when it comes to testicles, we're talking more probably now about fertility side of things. So in terms of trying to keep your testicles healthy and the sperm inside healthy, it's all about temperature and lifestyle. So you'll often see when couples are trying to fall pregnant that they're told to like keep their testicles as cool as possible. So by that I don't mean ice packs. And I can see a lot of men who come saying, "Oh, I'm putting ice packs on my testicles every day," and I'm like, "Oh,
Oh, God.
you're probably doing the wrong thing there." But it's just, wearing really tight underwear, wearing lycra, hardcore cycling in your lycra where you've got a bicycle seat pushing into your perineum for 2 or 3 hours every day. All of those things that might increase the temperature of the testicle can have a negative effect on the testicles. And then, in terms of lifestyle, loads of things to talk about in regards to alcohol, your diet, hormones, supplements. Don't get me started on supplements. Someone's making a lot of money. There's all these things that men can do to try and improve the sperm health, but maybe we touch on that a bit later when you talk about fertility.
I will touch on.
Penile health.
Sorry, carry on.
Yeah. I was going to say penile health is really just important to keep an eye on the penile skin, particularly when it comes to foreskins, and know that there is something called penile cancer. So most men have never even heard of penile cancer. It's incredibly rare, but it's something that's, actually if you have a foreskin, not if you don't have a foreskin, but it's something that men need to be aware of. So skin changes around the foreskin. Is the foreskin getting tighter? Lumps, bumps, red sores, sexually transmitted infections. Yeah, the skin on the penis is really important. Sorry, you were going to ask me about supplements, weren't you?
I'm going to come back to supplements. I'll ask you first about. So, Asia told us about the vulva, that we shouldn't use soaps and things like that on our vulva. What about the penis? Is it okay to use shower gel and those sorts of things and soaps and things on the penis to keep it clean?
So most people are fine just with your average soap. But if I'm seeing someone who's starting to have pain or discomfort or tightness or itchiness or discomfort having sex, the first thing I do is stop soap in the shower. So but that is, it is a minority of men. But if they come to me and say, "Look, I'm starting to notice changes on the skin of the penis, or it's getting tighter or uncomfortable," we do a little regime. So the first thing I will say to them is, after you do a wee, and you pull your trousers up, do you ever think, gosh, I leak 1 or 2 drops of urine? And almost all the men who I speak to who are coming with a problem will say, if they have a foreskin, oh, yes, I do. How did you know that? And so you say, well, look, the problem is urine and irritation. So what happens is the urine gets caught between the inside of the foreskin and the head of the penis, and it causes trapping, and it's that urine that causes the irritation. And then the soap irritates the skin as well. And so the first thing we do is we swap to a soap-free wash. And then what I start getting them to do is get some tissue and dry themselves and empty out their urethra as much as possible. And just those 2 little steps can help a huge proportion of men before we start even thinking about steroids and different creams and topical ointments I can use on the foreskin before moving down towards a surgical answer of potentially having a circumcision.
Thank you. And yeah, supplements. Okay. Deep breath, Pippa. I have always had an issue with supplements, and we have supplements now. I'm actually doing some research, a couple of research projects on supplements. They're everywhere. In my view, I haven't looked at the men's health ones, but the women's health ones, I think almost all of them are non-evidence based. They say they're evidence based, but they're not. But they're being sold in the gazillions with testimonials about these women saying, yes, it makes me feel better. There's ones for endometriosis. There's ones for menopause. There's one for fertility. What's the situation in men's health? Is it as bad?
It's awful,
Oh,
honestly, because when you take an infertile couple, they tend to be young, healthy people who cannot get their head around that something is not right and they have no control over that. So, this is a vulnerable group of people who will try anything. And so they are, understandably doing everything they can do to try and improve their health. And so they will be, with the patients who come and see me with like 10 different bottles of, I'm taking this supplement and this one and this coenzyme and this antioxidant, and my IVF clinic says that this is a great one. And actually, I point most patients towards the Cochrane analysis. So Cochrane do some great research, and they did a great analysis on the antioxidants for male fertility. And actually, what they showed, out of the many, many, many thousands of articles out there, that most of them are utter rubbish. There are 7 good randomized controlled trials that have shown a very slight improvement in live birth rate. But what I say to all couples is when a couple comes to see me about fertility, they're never going to say, well, this month I'm going to change my diet, and next month I'm going to stop the smoking, and the month, they throw everything at it. And so it's very difficult to pick apart what is the thing that's making a difference. And so a lot of couples will come and say, well, look, I took the antioxidant and my sperm count is so much better now. And I'm just like, yeah, but was it that? And so I will say to most couples, look, if your diet is good and you're trying to get in like a lot of fruit and vegetables, and you're not drinking too much, and you stop the smoking, and you're keeping your testicles good, I don't have a huge belief in them. But if you want to, I point them to some of the cheaper antioxidants out there, saying, look, these are the ones with a little bit more research and evidence from them. I'm not overly impressed, but if you want to do something, take one. But the problem is, with anything that is not a proper medicine, it hasn't been tested properly, so we don't know what's in there. And you can take too much, and you can then start to have a negative effect, exactly the same as, and in or another topic, protein supplements, protein shakes. I'll say to men, are you taking protein supplements? Please stop, because we have no idea what's on the protein supplements. And there was a study a couple of years ago that looked into protein supplements, and the number of protein supplements where they had actually added testosterone, which we know has a negative effect on fertility, was significant. So I just say, look, if you're exercising and you want to do that, just eat more chicken. Let's just try and step away from everything that you don't understand or you don't have a full set of ingredients for. So yeah, no, I'm not a massive fan of supplements, but I know I'm probably in a minority, judging by the people who come to see me with these packs.
yeah. What's happening now, certainly in the menopause field, is we're getting a growing number of doctors who are launching their supplement range, which is non-evidence based as well. But now even the medics are jumping on the financial bandwagon. So for the patients, for the public, it's really difficult. And if you see a doctor peddling some supplements, you think, oh, they must be great. So it's all
Yeah.
got very, very muddy. Pippa, what about? Oh, yeah, carry on.
I was going to say, it is quite difficult for doctors to do research, isn't it? In terms of
Hmm.
ethics, money, finance, it's really hard for us to do good good studies. And so, yeah, I just feel really uncomfortable when patients take anything that I don't really think that there's much evidence for.
Are men taking anything else? So what about things like anabolic steroids?
Yep. Yep. So that's what I was saying, that in terms of taking the steroids or their testosterone from their gym trainer and not really understanding the implications that that has on fertility. And although the majority of men who take exogenous testosterone or steroids who have a really negative, because most men will then become infertile or their sperm count will drop to azoospermia, which means no sperm or near that. If they stop, 98% of men will recover, but there is a proportion of men who don't recover. And there's not enough information about that. And so when a couple comes through and, there's some men, it's very obvious, they walk through the door like that and they have to turn sideways to get through the door. And you sort of say, look, I don't care what you're doing, but we've got to be honest with each other. And I can do a blood test and work out very quickly what's going on. So it's very clear from the hormone blood tests I do when someone is taking something and not being honest about it. It's very obvious. So, yeah, don't take steroids if you want children.
That's another good bit of advice. So the anabolic steroids, are they just testosterone or are they anything else?
They'll have HCG injections as well. There's a whole array of different supplements, injections, steroids, and huge doses as well of steroids and testosterone, things that we would never give. When we're improving people's testosterone, we're pushing them into a level which is normal. We're not pushing them into this level which is like super high and then has a detrimental effect. So yeah, you can get hold of anything on the black market from my feeling when I see patients.
Oh my God, this is much more worrying than I thought. And I've heard in the press, but I don't know if it's true, that it can really change men's personalities if they're taking these steroids.
Um, so there is the potential for a little bit more moodiness, a bit of grumpiness. So whenever I'm starting someone on testosterone, we do talk about some mood changes that they can have on the levels that we're giving them. We don't tend to be. There is a very small proportion of men that can sometimes feel a little bit depressed, but most men feel better with a normal testosterone. So I really am kind of pulling you back the whole time to saying, well, the people who are needing the testosterone had a really low level and we're pushing them into normal levels. I don't tend to see men with super high testosterone. They don't tend to come see me because they know I'm going to be stopping all of that medication. So they're a really difficult group to look after because they come in and they feel that they know a lot more than me, which maybe they do. But, the negative effects of it that I see are fertility wise.
Yeah. Right. Before we get to fertility, let's talk about sex. So I always say I've just written a book chapter about sex. I interviewed 51 women over 50 and I asked them all about their sex life. I asked them about lots of other things as well, but I asked them about their sex life. And I've always thought it obviously it can be difficult for a woman. There's some changes there that can be really detrimental to their sex life. But for men, I think for men of all ages, they've got to do some really difficult things. They've got to get an erection. Well, they've got to learn how to do foreplay for sure. But let's park that. Let's talk about the penis. So with their penis, they've got to get an erection. They've got to maintain an erection, and really they need to have an orgasm, but not too soon, not too late. They want to try and read the whole situation, and
A
there's
lot of
problems with
pressure.
too early. So I mean that's a huge amount of pressure. So
Mm.
what sort of things can be a problem there, and what about as men age?
So I think in terms of men and their erections, the most important thing I always tried to get across to men who walk through my door, 45, 50, who are like, oh my God, there's something awful is happening. My erection is not what it was when I was 18. And the shock when you say to men, this is aging, this is normal, you will lose your erection strength as you get older. This is what happens. And 40% of men over the age of 40 have erectile dysfunction, 50% over 50. It's inevitable. The sort of the complex process that goes into erection of needing to have a good arterial blood flow. You need to have no problems with your veins. We need to have normal tissues, connective tissues, and then we haven't even gone into the kind of the brain side of things. This is just the erection, but when we're constantly told when we're younger, aren't we? Don't smoke. Make sure your diet is good. Keep your cholesterol low. And I think everyone always just thinks about their heart in that regard, but actually, the blood vessels to your penis are thinner than the blood vessels to the heart, and so men will get erectile dysfunction before they get heart disease. So if a man walks through our door, 40s, 50s, saying, there's something going on with the penis, the erection is not what it was, apart from me saying, look, this is normal and this is how we are going to manage it, the most important thing I say to them is, this is a marker of heart disease. So it's really important that you understand in about 5 years' time, the heart will start to be showing these effects as well. And so you need to see your GP. We need to be getting your blood pressure under control. You need to not be smoking. You need to be trying to lose weight. You need to be exercising. And so it's a really public health orientated appointment, that first one, when you see a man with erectile dysfunction as they age. And that can really shock men. And often, you say to someone, you shouldn't smoke and you shouldn't eat fatty food. It's bad for your heart. They're a bit like, okay. But actually, if you say, well, it's going to have a really negative effect on your erections, and okay, well, we'll think about, potentially changing things. And so as men age, this is what happens for younger men. So there is often a big issue with younger people, and it tends to be that those will be I've always had problems with my erections, or I was really nervous when we started having sex and it's never quite been normal. It's never been what I thought it was going to be. It's never been what I thought it was going to be looking at the videos. And then that's obviously a different side of things. And that's more when we need to get involved with the brain. Although I say to all of my men, whether they're 80 or whether they're 20, my men, that sounded wrong. All of my patients, in terms of, as you start to have struggle with the erections, if you have an event where maybe you were with a partner and the erection didn't go as you thought it was going to be, the next time you have sex, there will always be this little person sitting on your shoulder, whispering in your ear, I wonder if it's going to work. And if you start having those fears and those concerns, the first thing your body does when you get anxious is release adrenaline. And if you release adrenaline, that's the fight or flight drug. You don't want an erection when you're fighting or flighting, you will lose your erection. And so with any man with erectile dysfunction, it's pointless just taking the treatment. You have to work on your head and you have to think about, right, how can we psychologically support you? And there's not enough psychological support for men. They definitely, there's a real fear of people being classified as this is all in your head, and it never is. But you also have to accept your head will not be helping you in this situation. And then we kind of start getting to the right, well, how can we cure this? And with older men with erectile dysfunction, I am very clear, you cannot cure erectile dysfunction. We can't fix those blood vessels. They're just too small. So it is a matter of managing it. And that's a treatment ladder. And there are some patients, younger patients in particular, who are really unhappy with that line from me, that we cannot cure this. It is a matter of sort of medically managing it. With a younger group with the more psychogenic erectile dysfunction, what's really good is if we start the treatment ladder, and we'll go through that, and they start to see, oh, my erections are fine, and then they get in a relationship with someone who is supportive and kind, then they'll come back and say, oh, it was amazing, we had sex last week and it worked fine, I didn't need the tablet. And then we can start dropping down the ladder and we stop the ladder. So that's really nice for them to hear, look, we're just doing this to give you the psychological support and what you need to give you the confidence. Because if you imagine as a man who is single, who has to go and have sex with someone for the first time and not be sure whether the erection is going to work, and how is this stranger going to react, and how much worse that will make it. They get in this awful vicious cycle. So it's terrible. So, number one treatment for younger men in erectile dysfunction is to find a nice partner, and then we can build on that. But it's almost impossible. So it's really difficult.
So there is the treatment for erectile dysfunction, that's not a cure, to manage it. So that I think most people have heard of the pill, so Viagra, the little blue pill.
Yeah.
Is there anything else that happens on that ladder?
Oh, my ladder's so big. My ladder is so long. Yes, we could work through it for hours. But so they're the oral tablets. So what we call PD5 inhibitors, and so the little blue tablet you'll have heard of. But actually, there's lots of different brands and there's lots of different makes, and some work better for men than others. So maybe someone will come and say, "Well, I tried that tablet and it didn't work. So this is a disaster." And actually, each of those medications is very specific. So I'll say to a patient who might have tried sildenafil, which is the first tablet, the little blue tablet, and I'll say, well, how did you take it? Because it's really specific. So sildenafil, you have to take 1 hour before you're going to masturbate or have sex, and you have to have no food in your stomach. Then
Wow.
there is the other tablet called tadalafil. Now, tadalafil is you take 4 hours before, and it doesn't matter if there's food in your stomach, and it lasts 36 hours, whereas the sildenafil lasts a much shorter period. So, we'll play with different tablets. How are you taking it? Are you doing it right? Various ways, and there are other tablets for them to try. There's the tablet that you can take just before sex, which works really well if you know you have sex on Sunday morning at 8 o'clock every week. But actually, for a young person, to think, oh my God, I need to take this tablet 3 hours before, but I've met her and we're going to have sex now. What's to happen? So there's another tablet where you can take a small dose tablet every morning, whether you're going to have sex or not. And that's just improving the blood flow to the penis. And that tablet is a really good tablet for younger people because the not so much the placebo effect, but the thought of, well, I took my tablet this morning, so everything will be fine is really useful. So first of all, there's those tablets, and they all work to relax the smooth muscles, improve the blood flow to the penis, and improve that blood flowing into the penis. And it's the brilliant tablet, and that they actually got that tablet from, they were testing it for heart disease, and they had all the men come back and they said, how did you find your heart disease? And they're like, well, bugger the heart disease, it's brilliant for my erection. And so it was that was invented, that changed the face of of the world when it came to erectile dysfunction. So the tablets are really good, although I suppose I should work one step down, just reiterate again how important lifestyle is. So lose the weight, going to the gym, get your blood pressure under control, getting your cholesterol under control. All of those things make a big difference. So it's important to do. And then you had the tablets. And then the next step is a different form of medication, which is sort of direct onto the penis. So all the oral tablets can have side effects. So because they cause vasodilation, so blood vessels opening, some people will get side effects of, because you have it everywhere, they'll get flushing, they can get headache, indigestion, some muscle cramps. So some people don't like the side effects, although the side effects are rare. And I think there's often a thought that I have heart disease, so I can't take those tablets. And I don't know where that's come from. Probably because they invented them from patients on heart disease. But actually, it's not a contraindication that if you have heart disease you can't take it. But there are some medications that lower the blood pressure, which we call nitrate medications, where we need to be careful. So it just means a little bit more help from your doctor to manage it. But most people can take them, unless A, they're not working, or B, the side effect profile is not great. And then the next step is medications direct onto the penis. And so that means there's no systemic effects, which some people like. And so there's a tablet you can put down the urethra, so down the tube that you pee out of. There's a liquid you can squirt down, and those are all, they're okay. But then the next one on my ladder, and I normally feel like I need to lock the door before I tell men about this because they want to run away, is the injection. The injection into the penis. But oh my God, the injection is brilliant. So, although I think for most people, the thought of putting a little needle into your penis makes you want to run away from me, definitely. Once we try it and I show them how it works, and it is so incredibly effective, it works really well for many men. And then there are other things, vacuum pumps, the psychological help, all the way up the treatment ladder to the top of the ladder, which is a penile implant.
Wow, I love it when I learn something from my podcast. I didn't know your ladder was so big. I'm glad I asked. I remember when I was doing my PhD, I had a paper that I stuck on my wall where a guy had done an N of one, so just himself. So this would have been in the 80s, early 80s, and he'd injected something, I don't know what, into his penis. And I think he had an erection for something like a week.
Yeah.
I found it
So
fascinating.
so we warn all of our patients that one of the risks is a really small risk, but one of the risks, particularly with the injection, is an erection that doesn't go away. And I'll just say this really carefully: that is an emergency. So if you were to get an erection that didn't go away after any of those treatments, what we want you to do is exercise. So you need to try and pull the blood out of the penis. So I say, you go for a run, you do sit-ups, anything you can. And if the erection has not gone away by 3 to 4 hours, you need to go to your local A&E, because it is a problem. Because the longer that, when you have an erection, it's basically a compartment syndrome. So you're not getting blood flowing in and out, so the oxygenation is not so great. So once you get to 4 hours, the fibrosis and the scarring to the penis is really significant. So that is an emergency. We know how to deal with it. You just come to hospital and we can sort it out for you very quickly. The longer men don't come to us with that problem, the harder it is to get that problem away and the more trouble we run into. So I'm waiting for you in A&E. Have you ever had that problem?
Wow. And just going back to men that are, I just thought when you said about men coming to your clinic and they're not having an erection, and then you can often understand that this is maybe heart disease further along in a few years' time. So I just worry about those men who don't realise that and don't realise it's a problem. So maybe they're single or they're not having sex with their partner anymore, and they just think, okay, it's just something I live with. So if they are having problems with their erection, they should come and see you. Nothing to do with their sexual activity. They should come and see you. Is that right?
Absolutely. They don't even need to come and see me. They need to go to their GP and say, this is a problem that's happening, and men are not good at going to the GP. We get to that kind of 40 years old and you need to go to your GP and get some tests done, after the age of 40. You need to get monitored every now and then. You need to make sure your blood pressure is under control. So it is a marker. So we really try and educate primary care that if a man comes to you with erectile dysfunction as they're getting older, you need to look at the whole medical picture here.
Wow. Okay, really interesting. So we talked about erection. What about ejaculation? So there are some men that ejaculate too soon, some that can't ejaculate. And I've had a lot of male friends talk to me about the fact that they have a problem now as they've got older of actually having an orgasm. So if this happens, what can we do about it?
So I have to say I much prefer looking after erection problems than ejaculation problems because they're so much easier to deal with. So ejaculation problems are totally separate. So, erection is all about the penis and the blood flow. Ejaculation and orgasm is from the brain. It's from the brainstem. It's from, it's central. So it's not so easy. It's not, oh, here, take a tablet. As men get older, two things happen actually. So a huge proportion of men will find that they start ejaculating quicker and quicker as they get older. So that is actually very common. So men will say, I used to be able to last, hours, and now I'm really not. And so the first thing you need to kind of find out from men is, right, well, what do you mean by you're ejaculating too quickly? So premature ejaculation is defined as intra-penetration time of less than 1 minute. So I do get men looking a bit confused and say, oh, no, I can go for like 25 minutes. I just, I thought that was too short. Again, movies, what they're looking at, things are different. But so some men will find that actually it's far less than 1 minute. So they will penetrate their partner and ejaculate straight away. And there are a number of things that, again, tips and tricks that we can try before you get to sort of tablets. But simple things like the stop-start technique. So if you're finding you're just getting too excited too quickly, you pull out, go back to foreplay, really important. You try and decrease sensation. So using a condom can decrease sensation. There are sprays, local anesthetic sprays out there that you can spray on the top of the penis, which can make it a little bit numb. There's clamp technique. And then I will talk to a lot of patients about, look, have you got a vibrator at home? A look of horror from some people going, no, why would I do that? And I said, well, look, even if you ejaculate really quickly, it doesn't mean you're not having fun or not enjoying it. So it's all about your partner then. So if you are worried that you're ejaculating too fast to satisfy your partner, then you swap and change in between vibrators, in between your penis, in between your hands. There's a whole education out there about vibrators, and I think in a lot of people's mind they have that. Do you remember 20 years ago, there was something that looked like a little animal, this big purple thing that kind of terrified people. But actually, sexual toys and vibrators and things that are on the market now are very discreet. There's some really nice ones out there that can be incredibly helpful. So number one, you start doing that, you start taking the pressure off a little bit. So that's my kind of treatment line. There are then tablets that you can take that can try and increase the time slightly by a couple of minutes. They are a version of an antidepressant, and some people don't like the side effects, and a lot of people don't want that. People don't tend to take them for a long time. But if men are very distressed by it, then we absolutely can try the tablet. So again, there's a whole range of things. And then when it comes to not being able to ejaculate, so you have to be really careful with your words and finding out exactly what the problem is, because sometimes men will ejaculate but not orgasm. Sometimes they will orgasm but not ejaculate. And all of those have different things that have causing them. So someone might say, well, look, I'm orgasming, but I'm not producing anything. There's something gone wrong. And there can be a whole reason. There could be a blockage. When men ejaculate, that picture before, so where the fluid comes out of the prostate and should shoot forward, as you get older, the bladder neck can open and become not as tight as it was before, so the sperm just takes the path of least resistance, so it can go back into the bladder. That's a common problem for certain patients who are diabetic, or they might have had prostate surgery. So that can be a problem, but actually losing the ability to orgasm as you get older is really difficult to treat. And I have to say, it's probably the one that I kind of sweat about the most, because I know that what I can do is limited. There are a couple of tablets that we use on the market to help, but I haven't had great response from them, and there are side effects with high blood pressure. So not orgasming is tricky.
It is tricky because I think what happens as couples get older as well is that the woman then thinks oh, I've got old, he's not attracted to me anymore, that's why he's not ejaculating and having an orgasm. You've said it a few times, but I think there's so much psychological pressure, and I think it can get more as they get older. And also women's genitals change as they get older, and they become more sensitive, they can become less lubricated, so then the guy thinks, oh, she's not excited, she doesn't fancy me anymore. So what I've said in my book chapter is I think everyone just needs to talk and understand that these are changes that happen, and it's not that no one doesn't fancy them anymore, it's just changes that can happen, and they just need to talk about it and maybe slightly change how they have sex together. There's
Yeah.
lots of things you can do.
I mean, I can't tell you how much joy I have when a man comes to see me with erectile dysfunction and brings his partner, because it's so rare. I'm like, bring your partner, because actually it starts a conversation, and then I can explain it in a different way that takes off the stress and the guilt and everything, and we can start to work together. So it's, yes, primarily it might be really good just to see a man by himself, but I will often say, bring your partner next time. Let's all have a chat about this together, to cover exactly what you've just said, Joyce. It's just, one of the things I did as in medical school is I did a psychology degree. I'm fascinated by psychology, and I think, probably 40% of my job is psychology. And that's with everything I do. It's, the talking side of things and helping people realize that things change. There's this, I often think it, as a woman, when you give birth, your body changes so significantly, and no one talks about the bad things that happen after you've given birth and how your body's never going to go back to what it was before. But it's just a given. Well, you gave birth, you pushed a baby out, that's happened, accept it. But if you say the same to a man in terms of you're just getting older, this is what happens, the kind of, no, you must change it, you must fix it. The kind of, I suppose, the, don't get old. We're all aging, and it's just accepting your body as it ages, and bringing in different things to bedroom as a couple. We see a lot of patients who have had surgery, which means that erections are almost impossible. Prostate surgery has really significant problems for men who have their prostate removed. Getting an erection can be very difficult, if not impossible, and trying to change how a couple thinks about what sex is, and trying to change what intimacy becomes, being intimate again, foreplay, kissing, all those things becoming important.
Exactly what I've written about. Just having a good old snog just for the snog's sake, and not having to lead to the whole pressure of, oh, that means we've got to have sex now. And I don't know if you know, but they do sell vibrators in Tesco. I have not a big Tesco near me, and I was very shocked and pleased that they sold a vibrator. So get some toys.
And vacuum pumps. I haven't spoken that much about vacuum pumps, but we talk about vacuum pumps with the erectile dysfunction ladder as well. Someone told me you can buy a vacuum pump from Tesco's as well.
Wow, I wasn't looking. I'll have a look. I'll have a look at see if you're Tesco or Sainsbury's or any other leading supermarket. um, let's move on to fertility. You've mentioned fertility a lot. So, in my experience, so in the 80s when I was first became an embryologist at a fertility clinic, there were very few doctors who actually examined the man. We examined the woman. She was, she'd come in the consultation, feet in the stirrups, checking out everything. But very few people check the man. But what we do is check the sperm count. So ideally, if a couple aren't getting pregnant, what do we need to do to look at male fertility?
Oh, it's so important. And I just get so frustrated when a couple comes to see me and they say, oh, well, we went through IVF 8 times and it's still not working. And now we're going to think about the man. And you just think, well, there's so much effort put into the female. Why aren't we doing this? And I think often, even with a really abnormal or poor sperm count, the thought is, well, you can go through IVF treatment because there's a couple of sperm there. So it doesn't really matter. But actually, why are there only a couple of sperm there? What is the matter? And infertility is a marker of poor male health. Infertile men get sicker younger, they die younger. There are reasons for this. So we should be looking at the man, absolutely. Um, I could scream about it. I could go on about it for years. The problem is actually there's not many people who are that interested in male infertility. So the access for men to see that is really difficult. And so you can go and see a fabulous urologist, and there are, thousands of fabulous urologists in the UK, but even they might not know that much about fertility. And so I often hear from patients navigating the system to try and see someone and see the right person who can help them is almost impossible. And you see people coming into your clinic and you start talking about the infertility and the look of kind of relief on their face of, oh my God, someone understands or knows what's going on. So we need to increase education amongst GPs, absolutely, because if a urologist doesn't know, the GP is not going to have that much access to it. So we need to understand about men, what does an abnormal sperm count look like? What should we be looking at? What should we be investigating? And then the other problem that comes with infertility is even if there is no problem with the woman and there is a big issue with the man, the funding or the looking after the IVF goes through the woman. They just, well, we can get some sperm, let's just ignore him. And so it is all focused on the woman. And there are understandably a lot of very frustrated men out there who just like, why has no one looked at me before? And so, when you see a patient, it's not just about, right, well, why is this going on? But can I make the sperm healthier to make your IVF outcomes better, or to downgrade the assisted reproductive technology? And what I mean by that is obviously there's many different things that you can do to have a baby. And talking to the most kind of hardcore of ICSI IVF, and I'm not sure, Joyce, your listeners, I don't want to talk about things that maybe people haven't gone through before, but there are much easier things for a woman to go through. And so maybe by making the sperm better, you can drop that down a little bit to make it easier for the woman.
Yeah, so it's absolutely just get advice about that. And one of the guests I had on my podcast a while ago now is Toby Trice, who's a racing driver, and him and his wife went through 2 rounds of IVF before someone finally examined him and they found he had a varicocele. So if people want to know more about that, and he's on a big mission now to
Mm.
improve awareness around men having conversations about their fertility and checking their testicles and penis, etc., and really being aware. And he knew he had a lump there, but he didn't know anything about it, didn't think about it, didn't join the dots. How would he? We've never been taught about these things, so that's something that's really important as well.
I suppose we're really naughty because we've talked about anatomy and I didn't talk about varicocele, the things that can go wrong with the testicles. So I suppose we should just put it out there just because you've said it now. So what's a varicocele? So a varicocele is just, if you imagine someone who's got really big varicose veins in their legs, it's just a varicose vein in the scrotum. And actually they can be huge or they can be not particularly significant. And we don't know why some men have huge varicoceles and no problems with their fertility, and other men have quite small varicocele but big problems. So we haven't quite worked out why are some men affected more than others. It's not going to kill you. It's nothing bad. It's incredibly common. So if I were to stop 100 men on the street and examine them, probably go to jail. But if I examine them, 10 to 15 of those men would have a varicocele. But actually, in my infertility clinic, probably 60% of men have a varicocele. So it's very common. They, apart from the negative effect on the fertility, and some men can get like a pain from it, it's a dull ache, a dragging sensation. Most men would have no idea. So it's not going to cause anything bad, and most men it has no effect on. But for men who are struggling to conceive or have problems with the sperm, it's the first thing that we need to try and rule out.
Yeah, thank you for that. And I was going to talk now about things that can go wrong. So you've talked about varicocele and testicular cancer and penile cancer. What else? So what about prostate cancer or anything? And obviously there's STIs. Anything else that can go wrong with male genitalia?
Oh my God, the list is like massive.
Sorry.
I think it is important to talk about prostate cancer because prostate cancer is such a common cancer, around the world, and it has such an effect on sexual function, fertility, on a man's well-being. Um, and so we'll see a lot of patients after they've had prostate cancer treatment, be it surgery, radiotherapy, or hormones, because there are different ways of treating prostate cancer depending on how aggressive it is. With the most aggressive tumors or metastatic tumors needing a hormone therapy, and by hormone therapy we actually take away their testosterone completely, so a man is pushed into that is a real hardcore, we want to call it the male menopause, whatever, but we take away all of the testosterone, so they lose their libido, tiredness, fatigue, weight gain, really, really difficult and hardcore. To radiotherapy and surgery, where actually the effects on the erections is dependent on how bad the disease is and also how good your surgeon is and how much radiotherapy you need. So it can be quite variable, but there will almost certainly be an element of erectile dysfunction following that. And for some men, that can be catastrophic. Don't really care about my prostate. I just want to still be able to have sex. And that's really difficult. But again, there are many people up and down the country who can help men with that. So you just need to remember that if there are problems with the prostate cancer and erections, there are many andrologists like me up and down the country who can help with that.
Fantastic. And we've talked a lot in our institute about how we've often forgotten about the man. As we've said, in fertility treatment, it's always about the woman, even how it's funded. And
Mm,
some of my colleagues have done great studies where they've interviewed couples and found out about how many of the men really felt engaged, and lots of them said they didn't feel that they were even in the room. But
yeah.
what's really important, I think, with everything you've said, is that we've got to raise this conversation about male infertility, male sexual dysfunction, all of male cancers of those regions, and just really make sure that we haven't forgotten about the men and that these conversations are on the table. Men can sit in the pub, hopefully over a few pints, and have some discussions with other men about anything they may be worried about. I think that's a really good place to start. And then obviously go and see their doctor. I think women, because we have a menstrual cycle, we have periods, it's something that from a young age we've probably talked about more. But men, I do
Yeah.
think it's still quite taboo to talk about this between other men.
Absolutely, and if we're talking about pathology and things going wrong with the penis and the testicles, a really common problem is something called Peyronie's disease, and most people out there in the world are just like, I've never even heard of Peyronie's. And so Peyronie's disease is penile curvature. And it's because of fibrosis and scarring on the tissue that wraps around the muscles. And again, really common, between 7 and 12% of men will get Peyronie's disease as they age, with the most common age peak being about 50, but you can have it much younger. And so I will see many men who will come distraught. There is something awful going on with my penis. I can feel a lump. So with Peyronie's disease, if you imagine the penis with the muscles, there's a layer around it, and then you get a plaque. So this area of fibrosis, of scarring, that basically pulls the erection over. So it's not such a problem when men are flaccid with no erection, but when you get an erection, they can have so some men will just have a lump and no curvature. Some men can barely feel a lump, but the curvature can be as mild as nothing, 10 degrees, all the way to 180 degrees. And it's a very, very difficult disease to manage because you will get erectile, or men can get erectile dysfunction from it. Sex can become impossible. And from a body esteem point of view, the penis will get shorter, the penis will change to what they were used to, and they don't know what's going on. So, they come to us, I've got a lump in my penis. I'm really worried I've got cancer. My penis is starting to curve. What in hell's name is going on? And so again, and I'll say it is this disease. And they're like, I've never heard of that. For a disease that is, almost 10% of men get, that men will have never heard of about. you just don't find men are sitting down in the pub talking about this kind of stuff. They're embarrassed, and was it something I did? Is the doctor going to judge me? Is it because maybe I have sex different to other people? Do I masturbate in a funny way? And it's just not that at all. And the problem with it is treatment options are difficult because we will never give you back your penis that you had before. So that can be a really hard disease for men to have as well. So yes, we need to talk about all of these things. We could talk about penis and testicle pathology for days, Joyce.
we could. We could. I could easily do that. It's good that it's my
Maybe
job.
you need maybe you need more than just one podcast for the boys.
Yes, we do. We do. This is the start. It's whenever I do I'm doing these mini series now. So I'm sort of, when I first started the podcast, they were all a bit random, but now I'm putting them in mini series. And, when I decided to do understanding reproductive anatomy, I was like, why did I do that at the beginning? Why have I waited this is my third year. Why have I waited 3 years to talk about this? It's obvious. So, Pippa, we're almost at the end. So I always finish by asking, the podcast is called Why Didn't Anyone Tell Me This? Have you heard people say to you, actually, you've talked about so many things, but what's the sort of main things that they've said? Why didn't I know this before?
Why didn't I know that I was going to get erectile dysfunction as I get older? I think that is a really common one, like complete disbelief that this could happen as a normal part of aging. I think that's really common. And then, from an infertility point of view, why did no one tell me that, there was a male problem that could get fixed or get better? And then when it comes to things like Peyronie's, why didn't anyone tell me that, my penis could curve? There's just so much that we just don't, we don't even cover that well in medical school, to be honest. So I'm not expecting school and biology for it to cover. When a lot of the doctors and GPs don't know that much about these disease processes, we just need to get better at being more vocal about this. And obviously the internet is a good thing because people can go hunting and try and find out what's going on. But, as I say to most of my patients, everything on Google leads to death. So, you can really freak yourself out about things on Google. So find someone who can make it better and explain the situation for you.
And if in doubt about anything with your penis or your testicles or your prostate, please go and see your doctor and hopefully get referred to someone like Pippa and find out the correct information and the correct treatments.
Yeah.
For sure. Right. The final questions, which are just what I ask everybody. I'm a little bit obsessed about happiness, Pippa, and I've been asking people this since the beginning. And my next book is about health and happiness. I think it's really important. So just to finish off, to lighten up the mood, Pippa, what makes you What makes you happy, and where is your happy place?
So many things make me happy. In my lovely, lovely family, I have gorgeous kids and an amazing husband. Makes me really happy. At work, we do a lot of fertility preservation for younger people with cancer and trying to find sperm before they start their cancer treatment in really difficult rush situations. And when we help a child or an adolescent or a young man out and we can help them with their fertility later on, that makes me really happy. So those are my big ones, probably work-wise and family-wise. And my happy place, I love coming home in the evening and putting on my pajamas and sitting with the kids. Honestly, that is my happy place. Right here, where I'm sitting right now with the kids.
Fantastic. And Pippa, I always say this story, but I'm going to say it again. Our students are fed up. Well, they're not, because they're different every year. But we first met in Egypt on a camel. I always say it. I think I have been on a few camels in Egypt, but I think that was the one where one of my lovely sons had phoned me when we were on this camel ride and said to me, I know he listens to this, so he's going to be a bit, well, I won't say which one it is. I was on a camel with you in Egypt, and he said, at school today, I need a packed lunch.
I remember.
Yeah, what shall I do about that?
That Egypt trip was amazing, and meeting you on that camel was one of the funniest bits in my life. And I have a picture somewhere. I must send it to you
Oh
on
yes,
the
you
camera.
must do. Yes, I'll put that out on social media. So the very, very last question, which some people find a little bit hard, but again a bit of fun. Pippa, do you have advice that you would give your younger self?
It's all great. Yeah, life's good. I think I've been amazingly lucky. My job is phenomenal. I love my job. I've got lovely family, and I think being able to help people who'd really struggle to find the help that we can give is good. So yeah, no, it's all good. I mean, look, life goes up and down. It's got hard bits, it's got good bits, and just try and concentrate on the good bits.
Fantastic. That's brilliant advice. So Pippa, thank you so much. I really learned a lot. I didn't realize quite a few things that you said. So it's been an absolute pleasure. I'm sure lots of people are going to learn a lot. So thank you so much for coming on the podcast today.
Oh, so grateful that you've asked me. It's lovely to come and chat with you always. Thank you.
Thank you.